Hello, and welcome to Professor Truelove's Concepts for Nurses series. I am Professor Terry Truelove. And in this episode, another of the cardiac series, we will be discussing sinus rhythms. This is Sinus Rhythms Part 2. Sources for this episode include Cohn's Flip&See ECG, 4th edition. In our last episode, we discussed how there were times where normal sinus rhythm could have a slight variability in the regularity. This is an example where that regularity becomes notable, and we call this also a sinus arrhythmia. And this is because it is the heart's normal response to respirations, and it is caused by an inhibition of reflex vagal activity, or tone. During inspiration, an increase in the flow of blood back to the heart reduces vagal tone, which increases the heart rate. ECG complexes fall closer together, and this shortens the P to P interval, or the time elapsed between the two consecutive P waves. However, during expiration, the venous return decreases, which in turn increases vagal tone, slows the heart rate, and lengthens the P to P interval. Because it is a normal finding, sinus arrhythmia usually isn't significant and produces no symptoms. However, a marked variation in the P to P intervals in an older adult may indicate sick sinus syndrome, a related and potentially more serious phenomenon. So as you are looking at your EKG strip, what should you look for? Well, it is irregular, and this irregularity corresponds to the respiratory cycle. The difference between the shortest and longest P to P intervals and the shortest and longest R to R intervals exceed 0.12 seconds. Remember, it is common to see some variation in normal sinus rhythm. However, if the longest and shortest intervals exceed 0.12 seconds, it is properly called a sinus arrhythmia, and now it is worth noting. Further, the atrial and ventricular rates are within the normal limits, that is, between 60 and 100 beats per minute, and vary with the respirations, faster with inspiration and slower with expiration. All of the other parameters seen on the EKG strip are normal, except for the QT interval, which may vary slightly but should remain within normal limits. It's all in the breathing pattern. So, look for a peripheral pulse rate that increases during inspiration and decreases during expiration. If the arrhythmia is caused by an underlying condition, you may know signs and symptoms consistent with that condition. More serious is a condition called sinus arrest, seen here on a 6-second strip. Note the obvious lack of atrial or ventricular activity in the middle of this strip. Sinus arrest is caused by a lack of electrical activity in the atrium, a condition called atrial standstill. During atrial standstill, the atria aren't stimulated and an entire PQRST complex will be missing from the ECG strip. Except for the missing complex, also known as a pause, the ECG usually remains normal. Atrial standstill is called sinus pause when 1 or 2 beats aren't formed, and sinus arrest when 3 or more beats aren't formed. Sinus arrest closely resembles third-degree sinoatrial block, also called an exit block, on the EKG strip. Sinus arrest happens because the SA node fails to generate an impulse. It can be caused by a number of conditions, including acute infection, heart disease, and vagal stimulation. Sinus arrest may be associated with sick sinus syndrome. The clinical significance of sinus arrest depends on the patient's symptoms. If the patients are short and infrequent, the patient will most likely be asymptomatic and won't require treatment. Pauses of 2 to 3 seconds normally occur in healthy adults during sleep, and occasionally in patients with increased vagal tone or hypersensitive carotid sinus disease. This may occur in such conditions as sinus node disease, such as fibrosis and idiopathic degeneration, or with increased vagal tone, such as occurs with Valsalva's maneuver, carotid sinus massage, or vomiting. Medications such as digoxin, quinidine, procainamide, and salicylates can cause sinus arrest, especially if given at toxic levels. Excessive doses of beta-adrenergic blockers, such as metoprolol and propranolol, are also associated with episodes of sinus arrest. Other causes include cardiac disorders, such as chronic coronary artery disease, acute myocarditis, cardiomyopathy, and hypertensive heart disease, as well as acute inferior wall myocardial infarction, sick sinus syndrome, and an acute infection. Closely related to sinus arrest, but much more serious, is sick sinus syndrome, seen here. Notice that on the left-hand side of the strip is a tachycardic rate, followed by a pause, followed by a bradycardic rate. Sick sinus syndrome is also known as sinus nodal dysfunction, and that term actually refers to a wide spectrum of SA node abnormalities. You should know that the syndrome is caused by disturbances in the way impulses are generated at the SA node or by the inability to conduct impulses through and to the atrium. Sick sinus syndrome usually shows up as bradycardia, with episodes of sinus arrest and SA block interspersed with sudden, brief periods of rapid atrial fibrillation. Patients are also prone to paroxysms of other atrial tachyarrhythmias, such as atrial flutter and ectopic atrial tachycardia, a condition sometimes referred to as bradycardia tachycardia or Brady-Tachy syndrome. Most patients diagnosed with sick sinus syndrome are older than 50. It is rare in children, except after open heart surgery that results in SA nodal damage. The arrhythmia affects men and women equally. The onset is progressive, insidious, and chronic. Sick sinus syndrome is a result of the dysfunction of the sinus node's automaticity or an abnormal conduction or blockages of impulses coming out of the nodal region. These conditions, in turn, stem from a degeneration of the area's autonomic nervous system and partial destruction of the sinus node, as may occur with an interrupted blood supply from an event such as an anterior wall myocardial infarction. Conditions leading to the fibrosis of the SA node include increased age, atherosclerotic heart disease, hypertension, and cardiomyopathy. Trauma to the SA node caused by open heart surgery, especially valvular surgery, pericarditis, and rheumatic heart disease are also known causes of sick sinus syndrome, as well as autonomic disturbances affecting autonomic interventions, such as hypervagotonia and degeneration of the autonomic nervous system. Further, there are certain cardioactive medications, such as digoxin, beta-adrenergic blockers, and calcium channel blockers, which can lead to sick sinus syndrome. Because of the vagueness of the diagnosis, sick sinus syndrome can actually be many different things. This is because sick sinus syndrome encompasses several potential rhythm disturbances that may be intermittent or chronic. These rhythm disturbances include one or a combination of sinus bradycardia, sinoatrial block, sinus arrest, sinus bradycardia alternating with sinus tachycardia, episodes of atrial tachyarrhythmias such as atrial fibrillation and atrial flutter, and failure of the sinus node to increase heart rate with exercise. On the monitor or on ECG paper, sick sinus syndrome will look like an irregular rhythm with sinus pauses and abrupt rate changes. The atrial and ventricular rates may be fast, slow, or alternating between fast rates and slow rates that are interrupted by pauses. The P waves varies with the rhythm and usually precedes every QRS complex. The PR interval is usually within normal limits, but varies with changes in the rhythm and rate. The QRS complex and T wave are usually normal, as is the QT interval, which may vary with the rate and rhythm changes. Prolonged pauses with sick sinus syndrome cause syncope. Consider it significant any pause lasting more than 2 to 3 seconds. And we have reached the end of this episode. So that ends our podcast about the sinus rhythms. However, there's more rhythms than just sinus. For in future episodes, we will also look at junctional and even ventricular rhythms. For now, I hope you learned a little bit. I hope you come back, and if you do, we'll see you then.